Hasa ukiweza kichango kazi yake ya jikoni, beruni na marumba la lumba. twaliakata matatu, kusikia kuna vita, twajifunika visogo, usoni linachanika, beru lina marumba la lumba.
Hi and welcome. My name is Shabir Moosa. I'm a family physician in Soweto in the Chiawelo community practice. This is the first in a series that I'm trying to hold as the Wonka Africa president, to be able to share examples of family physicians who are working in different parts of Africa, who have a story to share. And I thought I'd start by sharing my story. I am, as I say, working in a small practice that we call a community practice. It's very much a part of the public service. And together with my colleagues, who I'm very pleased to see joining us today, these are participants or people who work in Chiawelo community practice that we'll be chatting to and we'll all be chatting to. So I will, in fact, because it's a small number of people, if you feel you'd like to make comments and speak, feel free to unmute yourself, but we can talk to that. So just lift your hand and we can have a comment, a question and answer session. So I just want to introduce the people who are around. Shivani Pillay is a clinical associate who works as a clinical officer, clinical physician assistant, works with me very closely and has been there right from the outset about 5-6 years ago. Welcome, Shivani, and thank you for joining us. And Shivani and the team, if you can unmute yourself and also show your video, at least the people on the call can see who is in this group. The other person that I'd start with introducing is Bongelani Nene. Bongelani is basically a community health worker, one of those who are a very leading light in our group of community health workers and does a great deal. You'll meet him now. There are others who I hope can join us that I've invited that will be able to share as community health workers what exactly they do in that space of Chiawelo. In addition to that, well, Refilwe is another community health worker that's just joined us. Refilwe Ndo is a community health worker. She's actually been there also, in fact, right from the beginning, quite a long time ago. Claudia Curry is a doctor, an intern, who's just been through from Monday. So she's basically an intern, but the other key person delivering care is the intern besides Shivani as the clinical associate. I thought that even though she's been there only a week, a few words about her insights on what exactly CCP is all about, and that perspective I think would be very useful for others to hear. So with that, I thought I'd start by sharing a video that that myself and the community health workers put together a few years ago. It was actually quite a while ago, almost 5 years ago. I'm not sure that Bongelani is in it, but I'm sure Refilwe, you're in the video. And I think it gives, it was literally a sort of a quickie job with telephone, with a handheld device, but it works pretty well in showing what we're all about. So let me just share quickly where you might find it if you need to find out more about the Chiawelo community practice. If you go to my website, profmusa.com, Chiawelo community practice is the first thing. You'll see an about, and then if you go down, the video is here. Sorry, it's not quite there. It's about CCP. There we go. And you can then look at this video, and in 20 minutes it gives you a reasonable idea of what it's all about. The plans to implement national health insurance. The 2011 Green Paper on NHI speaks of the priority of strengthening district health services. Government has issued provincial guidelines for the implementation of the three streams of PHC re-engineering for the current district health system: district clinical specialist teams, school health teams, and PHC outreach teams. We are implementing the PHC outreach team program using the National Department of Health's toolkit and trying to improve on it. Although government references this PHC program to Cuban and Brazilian experiences, it is actually a South African innovation. Cubans and Brazilians were inspired by the community-oriented primary care approach modeled by Sidney and Emily Kark in the 1930s in Phulela, KwaZulu-Natal. The Karks Wits students went to Phulela supported by a team. Their first innovation was to develop the community health center with team-based comprehensive care serving 30,000 people in the rural community of Phulela, where the norm in the country was private GP care. Their second innovation was to develop community-oriented primary care for small defined areas, which is based on combining personal care with public care. They examined the impact annually, comparing a new area with the previous areas. The Jarleys, Edward, a medical aide, and Amelia, a nurse, were also key to developments at Phulela. By 1948, there were more than 40 such CHCs in South Africa, and plans were afoot for a national health service similar to that in the United Kingdom. Their work spread throughout the world. However, the Karks were persecuted by the apartheid government and left to Jerusalem in 1958. COPC has taken root in many parts of the world: Israel, Spain, USA, Canada, Cuba, Brazil, etc. The PHC outreach program is based on municipal ward. Each ward is expected to have one or more PHC outreach teams composed of one professional nurse, one environmental health officer, and one health promotion practitioner, as well as 6 community health workers. They are expected, with one other professional nurse and enrolled nurse at the clinic, to serve a population of about 1,619 families, or 7,660 people, in accountable delivery of services. Each PHC outreach team will offer an integrated health service to the households and individual within the catchment area. The roles of the PHC outreach team are promoting health, preventing ill health, environmental health, psychosocial support, early detection of diseases, follow-up of adherence, minor ailments, and basic first aid. The roles of each community health worker allocated 270 households include health assessments, promoting the health of households and individuals, referring after basic screening, simple health interventions, and psychosocial support. There appear to be challenges with the implementation of the PHC outreach program. These are poor human resource planning, the lack of skills, and the lack of integration. It is becoming a glorified screening program and not community-oriented primary care. The concept of COPC is not completely understood nor being acknowledged, let alone celebrated in South Africa. The team from Josie Family Medicine, a research syndicate linked to the Wits Department of Family Medicine, has been attempting to implement COPC as the Karks did. We have set up a community practice, as we term it, in Soweto, as a real-life model suitable for national health insurance. Community practice has been modeled as a simple and practical framework for implementation, emerging from the Karks work and the worldwide work on COPC since. The model is simple. It consists of 4 blocks: deploying community health workers in the community, re-engineering PHC services, engaging with stakeholders, and health promotion. The community practice is allowing us to implement COPC easily and transferably, taking one ward with a small section of the CHC at a time. The idea is to keep these 4 elements in mind and build each up
cyclically in moving towards COPC. It is already contributing to important research and training. Chiawelo Community Practice is an example. Chiawelo was established as an ethnic extension to Soweto in 1956 for Tsonga and Venda-speaking residents. This was part of the state's strategy to sift black Africans into groupings that would later form the building blocks of the so-called independent homelands. Chiawelo consists of many wards, 11, 12, 15 and 19, with the Chiawelo CHC, the black square, at the edges of 3 of them. There are a whole host of services provided by the Community Health Center and its staff. Unfortunately, the service is very fragmented. Patients have to move from one section to another in strongly verticalized programs. Work on the Ward 11 PHC outreach team only began in January 2014 when the Josie Family Medicine team were given a small space in the Community Health Center. The Josie Family Medicine team began PHC outreach teamwork in Ward 11, employing 9 CHWs via VITS since February 2014 and obtaining a further 9 volunteers since March 2014. VITS has renovated and furnished the spaces allocated in Chiawelo to family medicine to serve as offices, seminar room, as well as consulting spaces. Let's take you through Chiawelo community practice using the model we've talked about before. Ward 11 consists of the upper half of the suburb of Chiawelo. CHWs are operative in houses across the Soweto part of Ward 11. The clip-sprayed part of Ward 11 is across the railway line and is not covered yet. A Google map of Ward 11, or just around the Community Health Center, was printed out with ward borders drawn. The whole area was crisscrossed by CHWs, with each and every household visited, and each family, even in backyard shacks, noted. A street summary list of all families was developed and helped us decide on the area we could cover. 9 CHWs with assistants were then deployed into a set of streets and families. Each CHW has been visiting a family to do a household assessment. This includes household details, including housing issues, a list of family members and household illness and health risk issues, HIV, TB, pregnancy, etc. This serves to register the family into the Chiawelo community practice. Each family is given a letter that states that a team at the Chiawelo community practice is providing all registered families in Ward 11 with all healthcare services daily, free, and in a patient-centered way. Patients may come by referral of CHWs or if they feel sick or need chronic medication. We are encouraging patients to make appointments to ensure short waiting times. CHWs are busy capturing data themselves and have already helped begin a community profile or diagnosis of Ward 11. They have mapped the community and registered 6,830 residents or 1,471 families of the estimated 12,000 residents or 3,800 families of Ward 11 using the National Department of Health tools. CHWs have also been tasked to build up the list of key stakeholders in the community and have mapped many resources in the community, for example, schools, churches, etc. that are put up in clinicians' consulting rooms. Clinicians facilitate the CHW's learning for 1 hour every afternoon using the National Department of Health training manual and key health documents. CHWs are busy developing a list of patients per condition such that they can map it onto the wall with different color pins. The clinicians are at the beginning of their time of the dynamics of the community and regularly discuss issues with CHWs, besides themselves going out with CHWs for prearranged necessary home visits on Wednesday afternoons. The CHWs are coordinated by a CHW supervisor, Bongani Rampwane. Analysis of the 1,471 families showed that there was 100% access to electricity, toilet, piped water and working fridges. 29% received grants and 1% seemed to be eligible for a grant. Health screening questions showed up some key problems. 452 people needing an HIV test, 91 people suspected of TB, 21 people needing home-based care, 73 women needing family planning, 57 pregnancies, and 31 newly delivered children. On a population level, the prominent chronic diseases were hypertension, diabetes, HIV, asthma, epilepsy, arthritis, and mental illness. While this data is not complete, it does provide us useful information. There were varying interpretations of the question by CHWs and some missed households. Patients come straight to the Chiawelo community practice for all services needed. They usually make an appointment. The office is coordinated by a CHW, Tuli Makausu. CHWs, as receptionists, collect information, make up a family folder. The clinician usually fetches the patient from the waiting room with the family folder, reviews the CHW file to understand the family and community, and then writes notes with instruction for CHWs to follow up. There is also a weekly discussion as a team on problem patients. The Chiawelo community practice is now a comprehensive service, from immunization to ARVs. All CHC processes and systems are respected. There is a paper trail for all work done in this space. Reports are provided monthly to the facility manager. The clinical associate, Ms. Shivani Pillai, is seeing all patients from Ward 11 currently. Utilization has grown from 4 visits per day in February 2014 to 30 per day in May, requiring additional nursing staff. We are building a profile of morbidity using the International Classification of Primary Care and exploring how integrated chronic disease management can improve utilization. There have been regular one-to-one discussions with a variety of stakeholders. They are on 3 levels: health system, intersectoral, and community. We have met with managers, nurses, allied healthcare workers, social workers, schools, traditional healers, churches, the CHC committee, etc. Considerable engagement has occurred with the ward committee of Ward 11. David Campi, as CHW, is coordinating this stakeholder engagement. A monthly meeting occurs every second Tuesday of the month with key stakeholders to work on priority issues. We are working with the councillor towards a quarterly-wide stakeholder meeting to engage a variety of stakeholders. We have begun secondary prevention based on the data collected, including following up on screening outcomes, for example, high numbers of people wanting HIV tests and TB suspects. CHWs are also using pivot tables to develop a clear list in their files of people to follow up. We have discussed a way forward for primary prevention and health promotion. Each CHW will be developing a weekly support or health literacy group meeting in the area. We're also considering using WhatsApp for group messages to residents with chronic diseases. We're also planning to visit schools in collaboration with the newly employed nurse. We're also planning a daily walking club for the ward with the occupational therapist and physiotherapist. Health promotion is complex, but it is evolving slowly based on our interaction with data from CHWs, practice, and community consultations.
CCP, CCP, Chiawelo community practice. CCP, CCP,
we make a difference in the community.
CCP, CCP,
we make the cocoa feel my better.
CCP, CCP,
We help people to help themselves.
CCP, CCP,
We bring change in this community.
CCP, CCP, CCP,
We bring better service to the community.
CCP, CCP, Chiawelo community practice. CCP, CCP, Chiawelo community practice. CCP, CCP, Chiawelo community practice.
Thank you. I hope that was useful to give everyone an understanding of what the concept behind CCP is and what we try to do there. Now I'm going to ask some of the people to talk a little bit. Bongelani, or perhaps Refilwe, you were there in that picture, Refilwe. Refilwe, can you unmute yourself and just show your picture if you can? Great, great. How are you, Refilwe?
I'm fine, and you?
Good, good, thank you. Did you see the picture of yourself there?
Yes, I did. That was a long time ago.
Long time ago. So Refil, what have your experiences been as a community health worker in Chiawelo? Tell us a little bit about how you see the CCP.
It's been a very good progress, and we've learned so much, very much. And so far, I think that we've helped the patients so much, and they find this program it's very beneficial for them because they've never really complained about the service.
Right.
They always asking, even today they always asking for Dr. Musa. Where's the Dr. Musa? It's always been Dr. Musa's department. They're still asking it even today, and we've managed to recruit a lot of people, like almost 90% of on our side
The
ward
pop.
11, they do come to Dr. Musa, all of them. Yeah, they find it very quick. It's a very quick service. They don't have to wait for long just to sort of like fetch their medication, and they get almost most of the services. Like when the child is sick and the adult is sick, they can both come to one department rather than going to different places. So yeah.
Right. Any other things that they like? You've said it's quick. You said they don't have to go to different departments. What else do you think that makes them like what they get?
The fact that I think they like the fact that they're seeing doctors mostly, other than more like nurses and everything, and they get a very good service. And they like the fact that they can consult for everything. If they came for their medication and at the same time they're sick, they just consult everything. They don't have to go to the other department for flu and then they come to fetch their medication. So everything is done there in one place.
Yeah.
And the other
Because in
medication
this,
that
like you say,
they're happy about is the mental one.
Right.
Mm.
So you said that they don't have to go. So even if they're chronic, let's say a chronic patient, they go to the chronic side in the big CHC. If they go chronic and say they've got a cold flu, are they sent to another side?
Yes.
And they don't do
They
this.
don't. No, they don't do this at CCP. Like if they came for their medication and at the same time they have maybe the other acute sickness, so they can just consult at once. They can feed them the chronic medication and talk about the other problems that they have.
And how do they find you? I mean, are you a difference as a community health worker in Chiawelo, in CCP? The people who come to CCP, do they appreciate you as a part of that mix?
Yeah, they do a lot because, it's good because they also know our name. Sometimes when they come in straight, they just say, I want this person. I'm this person's patient. So it becomes easier for them. And as for us, when we reach out to the community, for them, sometimes it's easy. They just say, can you book for me an appointment? And they're able to even voice out the other problems that they have and they're facing. So we're able to sort of like help them rather than they're complaining on the side and they're not getting any help. When the other gogos who go to the general side, they like complain, and sometimes you can't really help them if they're still going on that other side. But so far we've recruited a lot. Like a lot of the chronic patients are now interested in coming this side, even the other wards. Yeah.
Right. So in the ward that, Ward 11, the area we're dealing with, which is actually now 22,000 people that we've discovered are totally living there, and you'll have covered 90% of the people. Like you say, almost everybody is aware and comes to CCP as their first choice. And what you're saying is I like it because of the fact that you as a community health worker actually are able to do more because you are part of the team at CCP. Whereas in the other side of the clinic, you can't find ways to deal with their problem because you're not part of the team. Would it be wrong? Yeah? Because I think you say they're solving problems.
Yeah. They are, because like for example, if they have a problem with their medication and like they got it at CCP, or they have just any inquiries they want to make, it's easier for us to get back to them and help them out. If they, for example, also have a problem with their medication, maybe it's giving them a problem, it's easy for us to help them and say, no, you can come back and do 1, 2, 3. As of when they go to the other side, it's difficult because like they feel that we're not helping them much. If we send them back to those nurses, they're resistant somehow. Yeah. And we are able
True.
to help them with some other medication on how to take them, like how many times and how to take them and everything. So yeah.
And just to share with the audience, the community health workers are really quite solidly part of the team in Chiawelo community practice. In fact, they hold the whole process in the clinic itself. So that little space is being run almost by the community health workers. In fact, Bongelani is the other community health worker. Bongelani, do you want to share how the administration, how the clinic works, and how it links up a little bit to, how the clinic, that process at the clinic works with the community health workers? Bongelani is a community health worker also. Bongelani, you can unmute yourself. You can show your pictures so people don't only see me, they want to see you as well, if you can. Just
Okay,
a
I'll
brief
just
one.
show. I'll just show this one. Then
That's
I'll be
good
out.
enough. At least they can see who that was. And Refill, when you got a chance, just a quick one. 1 minute, and they can see you when you speak. All right, go for it, Bongelani.
Okay, Prof. I'm not sure where to start, but
Anyway.
but I'll start with CCP. At first, I was
Okay.
charmed. That's why I work for CCP. I was charmed. I saw how it can or help the community out there. So I saw that people will love it, and yes, people are liking it. And people do come to CCP. A lot of them now. When it comes to administration and how we're keeping files, yes, we're not 100% perfect, but we're trying by all means to do the right job. The files are there. Each and every community health worker, what I like about CCP is that each and every community health worker has that opportunity to talk with the doctor, or to read a doctor's note, or to know what the doctor wants from a patient, so that it will be easy for a CHW to do their work. And that's so awesome. It's a good thing. The other thing that was there at CCP now is not there, because of the challenges and what so on, is the health promotion part.
Yes.
It was easy before to do health promotion because we had a team that we formed. We were specifically doing health promotion, like we were focusing on health promotion, which it helps the community. People may ask, in what way? If a community health worker talks about something or teaches you about something at home, then we guys do health promotion campaigns, and we do health talks and health education. Eventually, what the community health worker taught that patient, the patient will still hear from us as health promotion team, and that eventually will stick to a patient, and the patient will eventually see that the community health worker was talking something good and something right. So eventually that patient will continue doing the good things. And the health promotion usually help the community at large, because the health promotion doesn't focus on the illness part alone, but there are some drugs out there, there are some teenage pregnancy out there, unemployment out there. So it usually cover all those things. So it used to be nice, but we had some challenges. Yeah, I don't want to go deeper, Prof.
No.
I think
Deeper is good. It's good. Thank you, Bonglani. Just to help the people who are watching the webinar to understand better. Essentially, I think when Shivani was showing us in the video, there was a orange file. There's a red file which is now brown because we don't have money for those files. Then each patient's file is a blue one, which is inside, which has the patient's information. And then there was an orange file, which you saw Shivani paging through, where she checks on it. But that actually has the registration form, which the community health worker collected when they first visited the home to kind of, engage with them and say, listen, I'm going to gather information. So that's the information that they have. And then often what we do is we get the community health workers to write a referral form to the doctor if they see a patient needs something from the clinicians. Then they write notes, and that's a referral form that comes through, and it's kept in that orange folder, which is a community health worker folder. And then when the clinician feels I need to send a message to a community health worker, they write in that orange folder on a sheet for the patient saying, Bongelani, please do get this patient to join the club, or this patient has a drug abuse problem, or there's a family challenge. Can you please, engage with them weekly, give them instructions. And that was a simple process, which we really don't have enough of it. And it's a small enough team. Sometimes it even happens verbally, but that's the system that we set in place. And that's what I think Bongelani was talking about, is that they give them instructions, and the community just puts them aside, and then the community health workers pick that up, and then they get this instruction. Then they write their notes, and it comes back to the doctor. So there's the communication, at least, some sort of coordination between the community health worker and the community health worker and the clinician. Mogalani, you mentioned that the health promotion also is a little challenged, and in fact, just to
Yes,
share
Prof.
the challenge was actually that before we were actually just a small team, and we were running in the video. You see, on half this sort of building is CCP, and in about 2-3 years ago, we took over the entire building and took over a whole lot of other community health workers who were employed in a different way, being much more politically connected, so came with all sorts of complications. And then we had to expand to cover more wards. I think that Refilwe was talking about, to now cover, about 3 other wards. And so the whole dynamic has changed a lot. And then the managers started putting pressure on the fact that we had people like David Kampi or Bongelani and some few of the community health workers, I think, trying to be providing leadership in terms of health promotion efforts. And they said, no, sorry, they have to go out in the field. They can't spend any time. They made it very difficult. And I think they undermined our ability to do health promotion as a team. So I think managers don't quite understand it. So Bongelani, what do you think of the managers, and the way they relate to CCP? And maybe also you can share a little bit about the appointment system and what you're trying to do.
Okay, I think Refilo wants to speak or something.
Okay, sorry, Refilo, go ahead. You want to say something?
No, I'm fine.
You're fine. All right, I'll just mute you until you want to, right? Go ahead, Bongelani.
Okay, can you repeat the question, Prof, about the managers?
Yeah, what's the story? What's this problem we're having? And you mentioned, I think, was it Refilwe, about the nurses? Why is there difficulty, you think, between what we do and what the managers are doing, and what the nurses are doing?
Oh, well, Prof, we don't know.
It's okay. You can share.
We don't know. The only thing that we know is that there is this union part. People are so believing in unions, and they don't want to do anything without unions. They always consult their unions. So these people always tell the community health workers, or I'm not talking about the managers now. I'm talking about the community health worker who come to the manager. They will tell us what to do and what's on and what not to do, which is not, when you follow all those things. It's like you won't have any experience if you follow those things. You won't have nothing. So they are really, really, really messing up with the community health workers' mind. When it comes to managers, really, I don't know, because at some point last year, they called me and Linda to do a wellness campaign, play a health promotion part for the whole facility. So we're like, you didn't want us to do this as CCP, but now you want us to do it for the whole clinic. Oh, because you're our manager, we won't say no. We will do it for you, but we don't like the way things are going. But yes, we did it. So yeah, at the same time this year, she called me alone and said, Bongilani, what's happening? There's no health awareness health campaign next year. What are you planning to do? And I was like, okay, I'll talk to CSWs and we'll see what we can do. Yet
Good.
I don't know what transpired back then, why they didn't want us to do the health promotion or the work that we're doing. I don't know. And I think
No,
it's all about Prof wants this, Musa wants that. Well, we had all those comments that we don't like Musa. Musa wants to change that. Musa wants to change this. So I think it's all back then. That's why they had something against you, which is, I don't know what was that.
Okay. History. No, I think it's mostly the fact that things are done differently. Bonnie's just joined us. She actually joined us as an attendee. So welcome, Bonnie. I hope you can hear us and you can speak. I've given you a chance to unmute, so you can just say hello. If you can show your video, it'd be really good. But thank you for joining us. Bonnie CVMCV is also a community health worker and joining us. Bonnie, but perhaps let's go to Shivani. Shivani, you're a community health worker, I mean, a clinical associate. And, you know, like this, the community health workers just said, you know, people see themselves as coming to the doctor. Yet you see half the patients or a third of the patients together with two other interns. So as we grew up, you know, from just the small ward 11 and suddenly took on 3 other wards and seeing about 80 patients a day, we brought on, you know, we managed to get community interns to move through CCP every week, once, 2 of them for the week. So it was actually quite difficult. So tell us a little bit, Shivani, about what your experience is, you know, a little bit about who you are and what your experience is. And I'll come back to Bonnie a little bit to ask you a little bit about how community health workers, how you started. So I think we missed a little bit of that. And if anybody has any questions, please feel free to use the Q&A. I think we have got the Q&A, or please put out your messages on the participants list, or pick up your hand and we can actually allow you to speak and ask questions. So Shivani, go ahead. Tell us a little bit about yourself, the profession, and your role in CCP. And
hi
show your
everyone.
video a little bit, just a minute or two. Great. Have you been able to? There you are. Good, good. Nice to see you.
So I think I started back in 2014 at CCP.
Right at the beginning,
so yeah, right at the beginning, we had 5 patients a day. So a clinical associate is basically a mid-level health worker. It's between the profession of a nurse and a doctor. And it's a 3-year degree there's 3 universities that are offering it, with now honors in emergency medicine, and there's going to be one in family medicine, I believe. So yes, I started in 2014 at CCP. It's grown a lot since then. As you've seen, we've taken up the whole space now. I think the one thing that I liked working at CCP is that you're not just pushing a queue. So if you work on the other side in the OPD, all you're doing is you see a piece of paper, you don't really see the patient, you're just prescribing their medication and then they go, even if it's an acute problem. Whereas in CCP, you have the time to patient, and the fact that we have community health workers is what makes the service different. It's what connects you to the patient in the community. So if there is a problem that you can't solve everything in one consultation, you always know that you have the community health worker that can go and ensure that your message is given to the patient, and the fact that they come back. So there is someone that's they know that they can't just run away. They know someone's gonna come and check on them and make sure they make their next appointment at the clinic.
Yep, good. You actually said that you use that continuity of care because they can come back to see you as well. You can say, come back to me.
Yes.
So there's a decent degree of continuity of care. But in fact, you also describe the continuity of care with the community health workers as well, that they form part of that continuity because there's a community health worker that's linked strictly to them. Which is quite important.
Yes.
And just to share with the audience, in fact, just, people say, well, you got very few patients. But the truth is that Shivani and the two doctors see a decent number of patients, about 25 a day, and that can be, most days. And we, in fact, did work in the community and found out that, that they use us almost 95%, like Refilwe talked about. They used us a lot. We are their first port of call. But when we asked them, when we looked at our utilization to the population that we have community health workers working with the community, our utilization rate is in fact less than 1, which is very, very low. So the community uses us a lot. They don't use anyone else, but their utilization is actually quite low. And we were worried. We said, why is it that they're not coming to us as much as we expect them to come? And where the private sector expects like 6 to 8 visits, and in the public service, it's expected with 3.5. And here we've got less than 1, which in fact gives us more time to do things right, like Shivani just said. We asked the community, what is the impact of the community health worker on the visit rate of patients? And half of them said the community health worker reduces my visits to the clinic, which is really great. And it speaks to the fact that Shivani uses them appropriately and finds ways in which they're connected up, they get support, and it's not she doing everything. And she's task shifting because there's no doctor there. She's the one main clinician besides Dr. Kabir, who's mostly supporting students who come along every 6 weeks for a few weeks. So Shivani is there. Now, Shivani, how do you deal with the fact, people say you're the doctor. They all think you're the doctor.
Yeah. Yeah.
They call you Dr. Pillay.
Yeah.
When Shivani is not a doctor.
Now.
But it's actually an accolade of the quality of the clinical associate training and the ability of Shivani as a clinical associate 3-year degree trained person to function pretty well in primary care. So what were the challenges when you started off? What do you think, do you think the training of clinical associates could be improved, in terms of you functioning in a sort of community practice environment? What do you think of your learning there and reflecting on community associate training?
So previously, when I was in university, we didn't have much primary care level training. We used to do, we did a lot at district hospitals and secondary hospitals. So I think we did a block in a CHC. Whereas now they are changing it. So we do have PCMP students that are coming to the practice. They do come for like 3 weeks at a time to do like normal OPD patients and COPD. So I think the course has changed, obviously, from when I was there. It gave, the fact that I worked in a district hospital as a student, I did have enough clinical knowledge to handle the patients that we were seeing at CCP, because it is basically also in a district level, there is a lot of these cases that we see. So I think I was equipped in that regard.
Yeah, no, I think you clearly were well equipped clinically, and that's, I think, the training in terms of getting you ready. But I think that the key challenge is for us to make, and I think then this was part of the negotiating of clinical associates becoming an accepted cadre in South Africa, there was quite a bit of resistance from nurses to have clinical associates. And in fact, we as family physicians tried to make the process move ahead by saying, no, a clinical associate will be trained for district hospitals and function in that space. But their abilities have clearly shown that they can do this all over. And I think Shivani has shown that even in a very, very strongly community-oriented space, she can do greatly. So thank you, Shivani. We'll come back to some of that. We've got Claudia. Claudia, Dr. Curry is an intern who has spent some time in our setting for the last week or so. So, Claudia, would you mind sharing your insights as an intern who's worked in the hospital and now worked generally for the last few months in a primary care environment with the normal clinics and community health centers in the primary care system of Joburg, and now you spent a week in CCP. It's been a little difficult with COVID to be able to experience the full range, but do you mind sharing a little bit of your thoughts and reflections?
Okay, I'm Claudia. I'm camera shy, so I'm not going to put my camera on.
You just for a second, at least they can see you for just a brief moment.
Okay. How do I do this?
Just under the video. That's it. Great, wonderful.
Hi.
Good enough.
Okay.
Thank you.
So I am a second-year intern at Barra. I was also actually a bit student, so I have been to Chiawelo as a third-year student as well.
All right, good.
And done like the community healthcare walking tour. I was there in 2015, 2016.
Right.
I'm currently based at a Chirwell CHC, where, like I think Bongani said earlier, we only see patients based on what they're presenting for. So we only see acute patients or chronic patients who have like emergency symptoms. Whereas Chiawelo been quite a unique experience, and it's been different from that. With the filing system, it's much easier to trace through the patient and have a look in the rest of the family's file to look if there's any chronic conditions going on. It's also really nice to have access to the community healthcare workers who can do home visits. If there's something you're worried about, like a patient who's got recurrent high HGTs or whatever, you can send them to go and make sure that the patients are compliant or aren't getting sick, aren't having DKAs and hypoglycemias or hypoglycemias if they're newly initiated on treatment at home. But yeah, it's been an interesting experience. It's been a bit different from Chirwell. So yeah.
True. And have you been able to link up with the community health workers, just like Shivani speaks of? Have you found that an easy thing to do?
So we haven't really, I think because we're there for so short, we don't really get the experience of getting feedback on issues. So like if you try and get a community health worker to go follow up on a patient, I mean, with only a week there, you don't really get a long-term follow-up in that sense. But I know I've seen, so like on the Tuesday, there's the meeting where you discuss patients, where we have seen patients, so other interns have referred patients to to community health workers who they've gone and given feedback. So it is quite nice to know that it is being followed up and it is being worked through and they are being referred back, even if it's not necessarily a continuity of care thing. I think also with COVID, it's been quite difficult for interns to engage with community healthcare workers. Whereas when I was a student, it seemed like there was a lot more active engagement. So I think it's a bit difficult to judge in this difficult, unique time.
Yeah, I know it's challenged, I think, a lot of what we've been doing. I mean, I think that our community health workers have been drawn in quite a bit into the sort of community health centers triaging process, which has been challenging. But have you usually when the intern comes along, because they spend just a week, we usually try to get an orientation in the Monday morning. Did you get that, Claudia? On the Monday? Usually a short orientation to the place and the concept. Did you get that? No.
Shivani took us for a sort of tour around the area
Right.
and
Give you some
or like
background.
the CHC, and then told us how the CPC, sorry, the CPC works, and then went through the filing system with us and how to refer to the ward-based outreach teams and the community workers.
Right. So basically, you know, to give you a week in a week, you know, which is really just 5 days, for you to come in and do 2/3 of the clinical work has been quite challenging. 2/3 being two interns and one clinical associate, who's the only constant there, besides one doctor, Dr. Kabir, who's actually doing a lot of teaching. So the three of the clinicians, we basically expecting these two interns to come in the morning, Monday, get an orientation. On a Tuesday and a Thursday, 8 to 9, there's that teaching, which, you know, hopefully we can instill some idea, reflect. It's an academic sort of reflection. Usually we have on a Wednesday morning in CCP some sort of a visit to the clubs. And I'll ask Rafil where to share a little bit about what the club is, or even Bonnie, if she's still there, to speak about the clubs. And then, you know, on Thursday afternoon, we were hoping that the interns would do a home visit, which is quite challenging now. And then on Fridays to meet with the interns, because they never interact with them. And it's been somewhat challenging to get that Friday morning meeting happening now with the COVID and its disruption. So thanks for that, Claudia. And perhaps I'll come back to you and we'll talk a little bit more. Let me ask Bonnie. Bonnie, do you mind sharing a little bit about, you know, what you as community health worker, your qualifications, you know, when you started, what were you expected to have, what sort of training you went through, and then tell us a little bit about the clubs, but just your qualifications when you came and how you got trained a little bit. What were the training sources that you had?
Okay, Prof. When I started coming in, it was like a job interview, and I had to produce my qualifications in terms of have I done any home-based training? Do I know anything about the health system? And how am I going to be of help with the kind of work that I want to venture into? After that, I was taken in, and I came from doing my home base with the NGO for some time before I went to school to say, let me just upgrade myself. Then I came back when I found out that now we are linked with helping within the clinics and having a chance of upgrading ourselves from what we knew as a home base at first. And then when it comes to learning, after learning everything, being with CCP and working with what you call working health clubs, and we call them working clubs. So it's like we had to go in there, register our grannies, actually find the history of all our patients, who's got what kind of illnesses, and how can we help as community health workers. Then it will be us thinking, having a plan that now within a month we are going to, after registering all the patients that we have, approximately if we have 50 patients in that club, then all those 50 patients will be registered. We'll have some kind of a register whereby every time we make a visit, we tick that we came in today and this is what we did. If we took their BPs on that particular day and their HGTs on how do they keep on with their health, then we know that the next coming visit, we know that the first lady, actually the question would be, does the exercise make an impact in changing their lives? So we would know if one wants to lose weight or one wants to keep healthy, one wants to know if there are joints and pains and everything, then it's all listed. We've got we used to have a booklet that we wrote everything, their BMIs and everything, before we went through this problem of the COVID. So it's the one that gave us some kind of how can I put it, some time off in going forward with all those plans, because they were just initiated before everything happened. So we kept record of everything, which we still do, have, so that when everything is it goes back to normal, we start again and start to see if in these working clubs people were helping themselves with the education that we are giving them, now that we cannot be in the same room as a lot of people, that they still do need to exercise, keep fit, drink their medication, and knowing that when we come back we would like to see some changes. So yeah.
No, thank you, Bonnie. In fact, these clubs, I think we sort of talked about it in the video, and then we set them up with the community health workers, where they were trained in a simple format for the clubs. We call them walking clubs, and then we changed the name to health clubs. And as Bonnie has said, the community health workers then brought their patients in their area, and often 2 or 3 or 4 community health workers would kind of bring their patients together, and they created about 4 to 6 clubs in this community of 22,000. Not a lot of people joining it, about 150 to 200 altogether, but that's the impact that they are sitting there and trying to look using a format of sort of tool to follow up on the patients, ticking their presence and doing some monthly weights and BMIs and seeing how they're taking medication. So it's been really good. So patients, how are they talking about it now? Because do they want the clubs back? How are they responding to you when you talk to them?
Yo, Prof, they want it back so much. So now it becomes difficult to even explain to them that, hey, come on, it's COVID time and they can't. And they be like, no, we'll just go through all the procedures. We'll have 50 members. Let's try having, okay, if you know that we have 50 in the club, just put 10. Then we'll every day you'll come and do it. And we're like, every day it's gonna be impossible, because now we have to accommodate all of you. And for a week, me spending my whole time in the working club, I'm neglecting other people. But they do want it back so much. They want it back because it made them feel in a way that they are keeping up. There's somebody watching. They feel like, they think even if they cannot do it on their own, they have somebody who's going to remind them that they have to do that. So if there's nobody there now, it feels like everything is going back to square one, and it feels so, I feel sorry for them.
Yeah, no, they appreciate it a lot, and it's been quite amazing the impact that one little thing has had. So, Kezia Lewins, Kezia, do you want to speak your comment out just to add some more voices? Kezia, let me just allow you to speak, and you can just quickly ask that question. Kezia, go ahead. And let's see who can respond to that. You can unmute yourself, but Kezia asked, and I'll just, oh, there you are.
Oh, sorry.
Go for it, Kezia. Go for it. Yes.
Logically incompetent. Hi, everyone. Thank you for a wonderful session. It's been absolutely fantastic. I just wanted to ask, this lovely model that you have at Chiawelo, have you been able to kind of advocate for it to be adopted at any of the other community healthcare clinics? I know Claudia spoke very briefly on it. And then I also just wanted to ask the members from the clinic, but particularly the community healthcare workers, how they've been affected by COVID in terms of the work that they do in the community and supporting the community members. Thank you so much.
No, thanks, Kezia. And perhaps, the community health workers can answer both questions. I see Bongelani's left, but maybe Bonnie or Refilwe, do you want to answer why is this, what is happening? We tried to implement it across the whole CHC Chiawelo, and there was problems. What was the problem there? And just to answer Kezia, this was advocated for the whole of Gauteng. The MEC came along. Were you there, Refilwe, when the MEC came? Were you there when the MEC came? Remember the MEC that said, no, this must be expanded? I forget her name now. Which one is it? The third MEC before. But what is the difficulty with us expanding into the whole CHC? What do you think?
Okay, can you hear me?
Yep, we can see you and hear you.
Okay, I
Good,
think
good.
to be honest, I just feel like maybe there was some bit of jealousy. They thought that you were just going to take over the whole clinic and everything, and I think they didn't quite understand it as to what plans you had, but the plans that you had for them, it was easier, it was quick, but I think they just didn't want to budge into the whole thing. They didn't want the change. So it was difficult to kind of like implement what you had in plan for them. But I feel when I look at it, it was going to work because you were trying to sort of like make people to make the lines to go faster and separate people in so that they'll know which way to go and everything rather than they get all mixed up. But then I guess it just didn't work because they were not interested. They were not even willing to listen and try it. That's why it failed. So to answer the COVID question,
Go ahead.
for us as CHWs, it's been quite challenging with the COVID because somehow we missed our clients. We were not allowed to like go into their houses and interact with them as usual, and it was difficult because at first we were not even allowed to go out to see them. We only saw them when they came into the clinic, and that's when we could like talk to them and ask them how they're doing. But then for now, it's been a little bit better because now we can like go to them, but we are only allowed to sort of like stand outside and talk to them. So they understand the social distance and everything, but we can't really go into their houses and sit down and everything, but we still go in and talk to them at least outside. But at first it was challenging because we couldn't even go in. Sometimes we could just at least try and stand at the gate and try and interact with them at a distance. It has been really a very difficult challenge with this COVID.
And still using your mask, surgical mask when you're going out, etc. So they
Yeah,
usually
and
go with
everything.
protection. Yeah.
Yeah.
I think the other thing that has happened is that the community health workers have been drawn into supporting the clinic in the triage process. So we can talk about that sort of approach a little bit just now in response. Let me ask Refilwe, sorry, Bonnie, if she'd like to speak a little bit, if Bonnie's still there, to talk a
Yes,
little bit
I
about
am.
how has COVID, challenged your work? I mean, the clubs for starters has stopped.
Yes, the caps have stopped, but I wanted to point out something on the factor of the managers resisting to do the advocacy for the change, that the very same procedure that you are doing in
Yes.
CCP. Because I remember
Yeah.
the time you used to have 12 members, which you made coordinators so that they can be the ones that are going around all the clinics,
Right.
so that they can advocate for what was happening in CCP. It couldn't happen because the managers, I felt they felt they were not competent enough to even to think about what was going to happen within their facility and how much of a change and easy things would have been if they have taken that then. Up until now, things could have been running a little bit better and smoothly, since there are things that are coming in, for instance, like your DNS, where patients are being referred to be delivered medication and all those things. If they could have agreed upon that during then, it could have been easy now to manage that.
Sure.
When it comes to the COVID situation, it has been very bad because now we have patients that have been infected and their families being affected with the pandemic. But now with us as community health workers, I have to see that patient of mine who has been isolated by the community itself and now has to isolate herself for the pandemic and isolate herself from the social life that the patient is supposed to be living. And all of that goes into their minds and takes too much of their strength, and they feel neglected, and they feel like this is the end of everything. And I must come in and give support, which is will come as a mental support, which somehow sometimes I've never been, I don't have experience of doing it. And I cannot say go to the clinic again, because now we are trying to minimize the number of people going to the clinic. So I have to do it myself also, and make sure that I give that patient some something to think about and something to hold on to, because now there's nobody to talk to. And the fact that I cannot even come in at the time, I cannot speak the problems that she's got outside of the house, because there might be a neighbor that is standing outside and listening to us. We need to find a space where we have to now speak, and everything that we talk about, he or she is not going to tell me everything, because now we are thinking of who's listening to my problems or problems at the end of the day. So it became too much of a problem. I don't want to talk about the PPEs, because that one is something else that
lots of fighting about PPE.
Exactly. So yeah.
Well, thanks, Bonnie.
Very
Thank you.
difficult.
So I hope that answers your question, Kezia, about the experience COVID has had. I think it's just generally created lots of disruption to the work process, and difficult to navigate that. I think there's almost a siege behavior amongst health professionals, like like was mentioned, that people are actually stopped from going out. So I think there's a lot of fear out there that senior health professionals are not accommodating. Remember that even though we felt as clinicians that the community health worker could still go out and should go out, provided they are adhering to sort of social distancing and other precautions, managers were just flat out, no, sorry, this is the way it is, and that's how they function. So I think it speaks to the question of how we as clinicians interact with the health system. As a clinician, when we started this project off, there was a great deal of resistance. It was started off because a manager just gave us the space. The entire space was refurbished using funds for research and employing even the community health workers in the first year, which allowed us to choose the community health workers we had chosen. And a lot of the people, the bright people you see, came through that kind of effort. When we were literally at the very last month of money available, the managers flat out refused to move the community health workers into our community health workers into the big system. And they could have, and they just refused. Until the community, who had in fact become very involved, and I think that we haven't quite shared as much of that, how we try to bring the community together. We engage with them regularly, we meet with them monthly, and in that engagement, right at the beginning, the key stakeholders somehow were available and walking around with the manager when the MEC came visiting. And the managers distinctly did not allow them to come via the CCP until somebody in the community told them, as they told the MEC as they're going out, that no, you can't not see this place. So please, let's go back. They came all the way back to CCP, and the community health workers were there. They were running it mostly. I think Shivani might have been there. Shivani, were you there when the MEC came along?
Yes, I was there.
Then you must. What happened there? Tell us what happened in that experience when the MEC came.
I don't think I was part of the whole meeting. I was busy seeing patients, but yeah, but I just remember that day.
Okay. Well, it was quite amazing because I wasn't there. None of us were there. It was the community health workers, and they sold the place. The MEC was bowled over. She says, I want this to happen. This is how the primary care is supposed to work. And then she called me all the way in Ghana, where I was in a meeting, to say, when can you implement this across the whole of Gauteng? Of course, when I came and she suddenly palmed me off to managers, it was diluted until it landed up going nowhere. And all we got was just the acceptance that we'll expand it, and just not and the fact that the community health workers were then accepted. So it was only because of the community health workers that we sustain this, because, and that they fought against the management. Now, you must remember that in the current health system, nurses dominate the current health system, primary healthcare system, together with public health managers who tend to be very oriented to public health approaches. And that's where these verticalized programs, and the nurses are very bought into that. They've learned to cope around it. And a lot of the challenge when we try to implement what we tried to implement, what we tried to get them to change over to was to say, listen, don't have this huge organization which sees 1,000 people or 800 people a day and churn them through like a sausage machine. Why don't you have small teams that look after, like we do, after a designated area? And we registered them. So Ward 11 had a community with a team. Like that, we said, let's create a team for each ward across the area. And the nurses were completely unhappy with it. Part of the thing that they didn't like very strongly was that we had a very strong appointment-based system. So Bongelani is not here, but this is something that he's busy trying to get happening. But with that time, we actually had it on a time, not even a day. Now we've slipped to day. So at that time, a patient could call a number, which we had a landline, and they could call that number and say, can I come in at Tuesday, 10 o'clock, or Tuesday at 2 o'clock? And they would be able to come. So our waiting times dropped dramatically, and the experience was considerably better. And the nurses actually didn't like that, because they liked the fact that they can get these patients coming in quickly, and by 12 o'clock the entire team is finished, and then everybody rests or disappears to go shopping and doing other things. And that's my private view about why there's such a great degree of resistance, because there's a lot of opportunity in crowds to do your own thing, if I might say that euphemistically. So I think that's what the team-based approach would have been much more accountable. Work in CCP is very strongly accountable, so it becomes quite challenging when you suddenly are like 2 or 3 or 4 in a team looking after patients, and you're held to account for outcomes. So I think that's been the difficulty across adoption. So let's perhaps just close. I don't know if there are any other questions. I think Colin Goldberg suggested that do some health education with patients in the waiting room, and it becomes more streamlined and less waiting times. Bonnie or Shivani, do you want to talk a little bit about that? Is that happening at the clinic? Do you think there's opportunity? Do you think, what are your thoughts about it, Shivani?
I think previously we did do that. We used to have community health workers educating patients, and then sometimes we used to have the questionnaire that the community health workers used to ask patients, the like smoking, alcohol, and we'd then see it in the consultation rooms and address it there. I think there is definitely potential for us to do that, especially like now with COVID, patients are much more scared to come to the clinic. So we can do a lot of education in the waiting room instead of patients they like talking. So generally they just talking to each other at that time. So if we could use the time more profitably by educating them on something, since we can't do any health promotion in the community at the moment, we can use the time that they're actually in the clinic to educate them.
Sure. Yeah, no, thanks. I think that, the community health workers, before, our waiting time was so short that patients come in and within a few minutes they've seen and then they left. So when we ran it before, and that's what we want to get to, we don't want patients to even wait. At one point, we in fact tried to do what Shivani just said, a much stronger population type screening tool, which we try to implement. The current tool the community health workers use is basically around very basic family-based information. So community health worker would go into a community, knock on a home door and talk to granny, who's usually there, and they would ask the question, which were very basic questions. Are there any chronic diseases? Is anyone needing family planning? Has anyone done an HIV test or needs it? And the questions were actually no more than about 15 at most. And these were sort of so few. When we looked at the data, it wasn't really that much in terms of impact for a clinical point of view. So, for example, it didn't ask anybody if they took alcohol, how much, or they smoked, whether they had a pap smear done, when was the last time, or do they do the test annually, when was the last test. So a lot of information was not collected in what we thought was a population-based approach. And then it was also a question with the granny who, I mean, if you asked her, tell me, does your granddaughter who's 15 need family planning? No, 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 we're a good Christian family. No such thing. Who's got HIV? No, no one needs HIV test here. And I think that was a real problem with the data being collected. You could see in the video that we did manage to collect some information, but there were challenges with that information. So we got a picture initially, and in fact, it hasn't changed dramatically, but we needed more to act more on it. So, I mean, in that video, you saw that we had, for example, almost 6% hypertensives. The current, you might say population prevalence of hypertension is about 12%. And, so you expect about 50% of them to be treated. So they're noticed by us because they get treated. Diabetes was like less than 2, whereas the current prevalence in South Africa is almost 8%. So clearly we're missing diabetics. But we try to act on these to get the community health workers screening, etc., and it went a little wrong. And I think when we tried the model that Shivani talked about, we got the community health workers to take tablets into the community, and they would use that try to get every individual and actually interview every individual. But it turned out a bit of a problem because the community health workers, some of them decided to use the tablet to make calls and bust the budget, and we had to stop it. So that came undone. And then what we did is at the clinic, tried to get them to screen patients. But the screening process took so long because it was a longish interview that it created a block in the clinic, a sort of a hurdle, and patients got very annoyed. And they said, no, please, we can't wait so long while your community health workers are talking to us. And so anyway, those are some of the dynamics of dealing with a population and population health. So the community health workers gathering information is a very important source of information. In the clinic itself, and I think that they also form part of the care system, the clinic itself, because of its very strong orientation towards patient and family and community, is very connected. It's the way we think, the way it should be designed is like that, and a small team dealing with a small population so that continuity coordination start emerging. Even though there's not necessarily one caregiver per person, a family doctor, GP. Here it's a team, but they still can be community, good elements of primary care, coordination, continuity, and comprehensiveness that can be achieved. And the moment you start ballooning it to be a big organization, if you don't break it up into small sub-organizations or teams, that element of comprehensiveness, coordination, continuity is lost. The patient-centeredness gets lost quite quickly, quite easily. And we've seen it in Chiawelo where we've expanded from, 1 ward to 4 wards. It's not as strong as it used to be. So this is, I think, some of the challenge. Let me perhaps, and then the third element of gathering information, which in the video we showed, was that of engaging with stakeholders. And we've mentioned we engage with a whole bundle of them. But perhaps Bonnie or Rafil, where you can talk about our community meetings once a month. How does that function, and how do you think, what do you think is the way people treat it? What are your thoughts on that? Do you want to share? Rafil, where? Bonnie.
The community meetings, I think that we used to invite all the other stakeholders that are in the community. That would be your traditional healers, your counselors, and the NGOs. Anyone that would make an impact within the community in terms of uplifting their own community. So they were given letters that they would be invited to come into the meeting so that they can have an ear or should I say some knowledge and knowing how far and how do we do things, what problems do we come across as the health system, and how can they help us in those situations whereby we need the most. For instance, when you come to the services of the environmental challenges that we have that become part of the burden of diseases that are making people sick outside there. So we'd have those kind of people attending the meetings. So in order to have a plan on how to deal with the environmental issues and so forth. So they would come in every end of the month, and then we would discuss all of those issues and share.
Yeah, true. And so we have this, we used to have the monthly meeting until COVID, about February, March, then it stopped. But what were the challenges, perhaps, or what were the things that we picked up? Maybe, Refilwe, you can answer. What sort of issues did we pick up when we were talking to the community that they said, no, these are problems, besides the clinic?
For example, they'll talk about the problems of maybe they had like the elderly who they'll make us aware of some of the elderly people who cannot reach the clinics. And the other thing that the stakeholders used to sort of like help us with when they were at the meetings talk about is making, also helping us in also making the community aware of us, and like furtherly explaining to them as to what exactly do we do, and that they should sort of like let us in, and they should like welcome us into their homes to help them, you know, in terms of what we do. And
so it's a good communication between us and key people in the community. And in terms of, you remember when we had the workshops, you know, where we sat and said, let's see what the priorities are. I think you must have also been part of that priority setting exercise. We came up with, every time we did it, we had about 3 or 4 in the last few years, and once a year, where we said, what do you see as the priority affecting your health in the community? And they came up with poverty and unemployment. They came up with drugs every time, which was is really a big problem in the community. And then the, you know, environmental issues, like Bonnie said, and then you know, I think it was teenage pregnancy. Those are the kinds of things that we can. So that was an important source of information, and also a source of communication. You know, to negotiate how we actually take up things. And it was one of the places where we sat. We now have this monthly meeting, and in it we use that opportunity to bounce off, because in the once a year meeting we set the, you know, set priorities, but every month we
And then what happened?
I think we lost Prof. I think we lost Prof.
Yeah, Nama, I think we did.
I hope I'm back now. Sorry, I think my internet cut off for a second or something.
Yes,
So,
we can
just to quickly, sorry, I think I was feeling, geez, I left you all alone. So just in quickly closing, we basically have got the health club, formed themselves, and they've been very active with all the support the community health gave, health workers have given. They form leaders amongst them, and they have been meeting us monthly. And in that, we've been basically exploring various health promotion opportunities. And it's been slightly challenged, as Bongelani said earlier. What do we focus on? We've had drug campaigns before. We've had walkathons. What else have we done, Bonnie and Philway? What sort of health promotion initiatives do you remember?
I remember the other ones we did was the pap smear one we did, but it was not something huge, but it was, yes, we did the pap smear campaigns within the health clubs. And then we did, what was it? Oh, was it drugs? You mentioned that one.
You did
I will
do the drugs
remember
one as
along the
well.
way,
You
yeah.
had the dialogues and the
And there was
walkathon.
that, yes, and we went to schools also to do
Yes.
teenage talks and everything that. And then we had we tried on it Dream Fields, which was about soccer, giving kids some
Yes,
a
yes.
chance to play with the kids. Yes, yeah. Quite a
So there have
few
been
that I
lots of
can remember.
initiatives, and a lot of it
Yeah.
has come largely because of the ability to harness the team in, as a family physician. We just try to pull people together and provide them opportunity, supportive leadership, supportive supervision, enabling people. And that to me is what family medicine in action is all about. But I think that the key thing in closing is that Chiawelo community practice is an opportunity for us to see the important role that well-trained doctors can have if they're trained in family medicine, can have on outcomes in the community in primary health care. And what we are doing in Chiawelo community practice is a model of community-oriented primary care, much more strongly, a good example of it, something that can be taken up. And we hope that many people will see what goes on in CCP and see what potential family doctors, well-trained family doctors can have on, on strengthening primary health care. I think there are a lot of system issues, and this particular series is about sharing that and allowing decision makers to hear the story that we are sharing, to understand that, we can do things differently. And that if you embrace the family doctor, if you embrace them, it doesn't need to be more expensive. It can be cheaper. And we've got evidence to suggest that it can be cheaper, because it's not just about the family doctor, but the leadership they provide to the team and the ability to empower that team. So I hope that you all have been able to see family medicine in action and what is possible. So we're going to have this as a weekly webinar on a Friday. You're welcome to share the news around. We're going to try to get a whole range of family doctors across Africa to share their stories, so that you can see what this discipline is all about and how we can alter the equation in Africa to make primary health care for all happen. So with that, thank you all very much. Thank you to those who've joined me from CCP, Shivani, Claudia, Refilwe, Bonnie, and Bongelani, and to all our guests who've joined us, all our attendees. Thank you very much. All of you, keep well, keep safe, enjoy your weekend. Bye-bye.
Bye. Bye. Thank you.